हाँ बस 2 मिनट लिंक आ रहा है लिंक आ रहा है कहाँ गया ये रहा नहीं लिंक है ना लिंक नहीं है लिंक भेजिए नहीं भेजा
सर गुड मॉर्निंग।
गुड मॉर्निंग विवेक, कैसे हो?
आई एम गुड सर, आप कैसे हैं?
बढ़िया बढ़िया, फर्स्ट क्लास
सर नाउ यू आर लाइव ऑन यूट्यूब।
बिल्कुल।
तुमने भेजा बस सर विद इन अ मिनट वील स्टार्ट सर, जस्ट गिव मी अ मिनट। पार्टिसिपेंट्स आर जॉइनिंग ना, सो मैं चाहता हूँ मैक्सिमम पार्टिसिपेंट्स को बेनिफिट मिले।
एक बार ज्वाइनिंग हो जाए तो जब आप शुरू करोगे तो फिर मैं अपना माइक अनम्यूट करूंगा, म्यूट करूंगा, ठीक है? अभी एक बार म्यूट करूंगा।
सर के सर?
हाँ चेतन
सर, आई थिंक नाउ इट्स टाइम टू स्टार्ट।
ठीक है, आप शुरू।
A very good morning to all the dignitaries who have joined from all over India. Today we have Dr. K.K. Gupta, who is a professor and head of Department of Periodontology and Implantology, Vyas Dental College, Jodhpur, Rajasthan. Dr. K.K. Gupta is a periodontist and implantologist currently working as professor and head at Vyas Dental College, Jodhpur, Rajasthan. He was program in charge of program graduate certificate in oral implantology, a joint venture of Indira Gandhi National Open Institute, University and Dental Council of India. He completed his BDS and MDS in periodontics in 1993 and 1998 from the prestigious King George Medical College, Lucknow. He has a teaching experience of 23 years and has more than 50 publications in his reputation, which are both national and international journals. His research thrust area lies in dental implants and perioplastic surgery. So Dr. K.K. Gupta would be speaking on the surgical smile designing, a multidisciplinary approach. Sir, we welcome you, sir, and we would request you to start your presentation, sir.
Thank you, Chetan, for introducing me. via your college and through your program, Period Shastra. Before starting, I would like to thanks Dr. Vivek Benz and Department of Periodontics, Saraswati Dental College and Hospital, and all your team for giving me a chance to interact with students and other periodontists and general practitioner on this platform. Chetan, my screen is visible.
Yes, sir.
Okay.
Perfect, sir.
Okay. So today's topic is surgical smile designing. Surgical smile designing, basically, my presentation will be focused on around the correction of gummy smile. Since gummy smile has various type of etiology, then gummy smile is a single problem, but their underlying cause could be many type, like maybe due to skeletal problem, maybe due to some soft tissue problem, maybe due to overgrown gingiva. So it is important to identify the problem and the treat accordingly. So before going to main presentation, I will discuss some short thing, like some small points on what are the golden rule of smile and what are the different aspect of smile. Before going to the surgical part, I will discuss some small things in some 10 to 20 slides. So this is a very popular slide on internet. Everyone must have seen what people notice first when they meet someone. So according to this, 47% people are noticing your smile. So that's why smile become very important, and smile are good looking. Our beauty is $1 million industry across the world. So everybody want to look good at their smiling part. When we are discussing about the smile, what are the different component of aesthetic smile? They are actually, we as a dentist mostly focusing on the teeth and gingiva part, but there are a facial component also which affect the smile, like some discrepancy or changes in hard tissue and soft tissue, especially area of perioral area like lips and other thing. And dental component of a smile is teeth and gingiva. So there are two parts, facial component and dental component. Facial component comprises of hard tissue and soft tissue, whereas the dental component comprises of teeth and gingiva. Vital element of smile designing, what are the different dental components? If you consider, look towards the tooth component, so when you are looking for a smile or designing for a smile or improving a smile, then you have to go through these points, like you have to keep in the mind what is the position of the dental midline, what is the incisal length, what is the dimension of tooth, what is the vertical dimension, what is horizontal dimension, what is the zenith point, especially when you are doing aesthetic crown lengthening, then you have to create zenith point accordingly. What is the axial inclination of the tooth? What is the interdental contact, where contact are proper or not? If contact is not proper, then it may lead to the black hole disease or loss of papilla. Where is the embrasure are placed? What is the sex, personality, and age of the patient? According to that, you have to keep in the mind shape and size of the tooth component, and symmetry and balance, of course, because bilateral symmetrical is required for anything. And when you come to the soft tissue component, it is the health of the gingiva in terms of quality and quantity, gingival level and harmony, interdental embrasure, and smile line. So we have to look all these things when we are looking for any smile or a smile component or gummy smile. Treatment modality basically depend on the type of pathosis, what kind of problem is there, then what that type of treatment you have to provide. Suppose if gingiva is hyperplastic or overgrown gingiva, then you have to go for the gingivectomy or crown lengthening. If there is a problem of recession, then you have to look for some orthodontic treatment or cosmetic periodontal plastic surgery using the soft tissue graft, guided tissue regeneration, correction of recession by various means. Over eruption, in cases of over eruption, you have to go for the orthodontic intrusion. Deficient pontic size, then you have to go for the ridge augmentation procedure, sometimes vertical, sometimes horizontal, sometimes combination of both. And if have major skeletal abnormality, then you have to look for the orthognathic surgery. Now come to the E-line or aesthetic line. What is E-line or aesthetic line? E-line is an imaginary line connecting the tip of the nose to most prominent portion of the chin on profile. Ideally, upper lip is 1 to 2 mm behind the lower lip, and lower lip is 2 to 3 millimeter behind the E-line. Any changes in the position of E-line as with relation to the lip indicate the abnormality in the upper lip or lower lip or both. Then according to go for a correction of the lip problem by use of filler and other things. Now come to the tooth dimension. What is the tooth dimension? Correct dental proportion is related to the facial morphology and essential in creating aesthetic pleasing smile. Central dominance, rule of central dominance is there, dictate that central must be dominant teeth in the arch and they must display pleasing proportion with the lateral and canine. The proportion of the central must be aesthetically and mathematically correct. The width to length ratio is 4 to 5. The shape and appearance of the central influences the placement of lateral and canine. We have all seen in our prosthetic training in undergraduate times, where there's how to place the central incisor in teeth setting, how to place the lateral and canine. So this is the rule. This is the why for central incisor, 100%. If their length is 100%, their width should be 80%. As I told you earlier, it's aligned in 4:5 ratio. Whereas when you go to the lateral incisor, according to as per length, their ratio of the width is 0.75. And in case of canine, it is 0.9 when compared to the 9. So this is the rule which we have to follow when creating a smile or doing aesthetic crown lengthening or soft tissue or hard tissue changes, or when we are sometimes we used to place veneer also. In those cases, you have to keep in the mind that what is the golden proportion of the tooth. Now come to the golden proportion. What is the golden proportion? It is expressed in numerical form and applied by classical mathematicians such as Euclid and Pythagoras in pursuit of universal divine harmony and balance. It has been applied to a lot of ancient Greek and Egyptian architecture and may be expressed as a ratio as 1.618 to 1. If the ratio is applied to the smile made up of central, lateral, and mesial of the canine, which is a major part of the tooth, which is shown in the smile, it shows that central incisor is 62% wider than the lateral incisor, which in turn 62% wider than the residual portion of the canine, which is mesial half, when viewed from the front. So this is a very important, sometimes when you are creating a smile or correcting a smile with the help of veneer or doing any crown lengthening, then you have to keep all these things in the mind. What is the role of maxillary canine? Maxillary canine, very important tooth, because when you look from the front, it's most of the time or in ideal position, its mesial half is only visible, distal half is not visible, although it's a bigger tooth. But due to their illusion effect, lateral looks wider than the canine, because during a smile only mesial half canine is visible, but lateral is visible 100%. So what is the role of maxillary canine? Maxillary canine is very critical in creating a pleasant smile. Junction between anterior and posterior tooth, because anterior teeth ends here and after that posterior teeth starts. It supports the frontal muscles. Size and shape of buccal corridor depends upon the placement and shape of the canine. Here again, I would like to report central is wider by the lateral by 2 to 3 millimeter and by canine 1 to 1.5 millimeter. Canine is wider than the lateral by 1 to 1.5 millimeter, and canine and central are longer by the lateral incisor by 1 to 1.5 millimeter. So this harmony must be remembered whenever you are doing any soft tissue or hard tissue changes, keeping in the pursuit of smile. And after that, maxillary bicuspid, like premolars started, which have important role in arch design and filling the buccal corridor. Now come to the interdental contact point. What is the interdental contact point? It is the some in posterior teeth. This is the contact point because where it is smaller. But in anterior region, it is called as contact area or something like that because it's broader. Like longest contact point or area between center and both the central incisor, it is most of the time 50% of area is in contact. Whereas when you go to the between the central and lateral, it is 40%, and between lateral and canine, it is the for 30%. So it is the shortest in canine and longest in central incisor. Interdental contact point, where the interdental contact area is end, that is the interdental contact point. These are the interdental contact point. The contact point of maxillary teeth are relevant for ensuring optimal pink aesthetic for patient with a high smile line or visible cervical margin. Means where high smile line means where lip are lifting too much or more than 3 mm of gingiva is exposed during the smile, or cervical third of maxillary teeth are visible during smile. So that is called the high cervical line. So old rule is the 5 mm rule that state that when the distance from the contact point to the interproximal osseous crest is 5 mm. When the rule 5 mm states that when the from contact point to the interproximal osseous crest is 5 mm or less, there is a complete fill of gingival embrasure with the interdental papilla. For every 1 mm above 5 mm, the chances of complete fill is progressively reduced by 50%. So when you are placing any implant or any crown, then you have to keep in the mind that distance from the interproximal contact to the your apical portion of contact point should be 5 mm or less than 5 mm. Because if this space will be more than the 5 mm, there will be the chances of black triangle or opening of the interdental papilla, or there will be chances of not complete filling of that space by the pink tissue. Like interdental contact area can be moved apically to close the gap. This can be achieved by the some orthodontic movement, because you can see here is the contact area is here, and this from this point apical point to the interproximal distance is more than the 5 millimeter of area. So in this case, this area is not going to fill by the gingival tissue. But when we make this contact broader, either by means of some restoration or orthodontic movement or something like that, then this will be filled, because his space from this point, like apical contact point to the interproximal bone, is reduced to the 5 mm or less than 5 millimeter. In those cases, it will going to the field. This type of smaller defect can also be filled by the by changing the restoration. So this is the case where the before and after picture are there. This is again where contact point is improved, contact area is improved, shifted apically, and this area is filled. And some surgical approach are also there, because you have to raise a partial thickness flap and shift the connective tissue, push it in coronal direction. But these are very difficult to maintain there. So nowadays, in smaller defect like 1 to 2 millimeter defect, we also use fillers, because fillers are very effective and they keep the area filled. Like 1 to 2 millimeter defect can be filled with the help of filler also, and you can get immediate result within a day or 2 days. Now come to the gingival zenith. Sorry. What is the gingival zenith or contour? The apex of gingival height contour on the anterior teeth is called the zenith. Like where is the most this apical part of gingiva is there. So it varies according to the tooth. Like in cases of central incisor, if you draw a line, vertical line, then the apex of the gingival contour is on somewhere distal third. It is not in middle third, but in case of lateral, it is in middle third, and in case of canine, it is in distal third. No, in case of canine, it is bicuspid, it is in central one. So this is the position of the zenith or gingival height contour, which you have to keep in the mind in cases of gingivectomy or aesthetic crown lengthening. Now come to this is the reverse triangle. It is very important when you are doing any gingivectomy or aesthetic crown lengthening, when you are including like lateral incisor, central incisor, and canine, because the gingival margin or gingival zenith of central incisor and canine is at one plane, and level of lateral incisor is on coronal direction from 1 to 2 millimeters. So when you draw a line from all these 3 points, you will found a reverse triangle, a scalloped reverse triangle due to their scalloping, because level of gingival margin of central incisor and canine is coronal to the lateral incisor. When we are making any composite veneer or something like that, and you want to give some elusive effect, suppose if space is less, but you want to give a bold look or narrowing look or widening look of the tooth, then you can change the plane. Like if your tooth is broader, area is broader, but if you want to give a narrow look, then always this face should be in different plane. Like if you give a convex shape, then it will look narrow. But at the same point, when is a space is less or narrow effect, but if you want to give a wider look, then you have to keep all the restoration in one place, so it will give you a broader look. Now the same is according to applied on the length. When if you want to give a longer look, like a smaller tooth, but if you want to for a smaller space, you want to give a longer look, then you have to keep all the restoration in the same plane. But if you want to give a certain look, then you have to keep it in different plane. So it will give some elusive effect. So this is also very important. Now, what is gummy smile? So gummy smile is referred as being case diagnosed in cases where during a smile, gingival display measure more than 3 mm from its margin to the upper lip line. According to Garber and Salama, it is called as a gummy smile. When more than 3 mm of gingiva is exposed during a smile, then it is called as a gummy smile. Etiology of gummy smile, there is a various etiology like vertical maxillary axis, where vertical part of maxilla or vertical portion of face is overgrown. Delayed passive eruption, where eruption is slow and lot of hard and soft tissue is grown over the cervical area. Gingival overgrowth, this is a completely soft tissue problem, or everything is normal but labial hyperactivity is too much, like upper lip is lifting too much during the smile, and lots of gingiva is exposed during the smile, or combination of these factors. So according to the etiology, you have to identify the etiology of gummy smile, and you have to correct those problems accordingly. Labial hyperactivity or contraction of upper lip which elevate the muscles. Some approaches are proposed to contain labial movements, such as surgical procedure given by Rosenbalt and Siman in 2006, and our use of medication like Botox and other thing. An alternative is a surgical procedure to remove a strip of alveolar mucosa described to reduce oral vestibule in interior region, and thus reduces the labial elevation and correcting the gummy smile problem. What are the treatment options? There are a different type of treatment options according to the treatment. Like one is orthognathic surgery. Orthognathic surgery in cases of where severe kind of vertical maxillary excesses, those cannot be corrected by the this lip repositioning or other thing, because it's actually vertical maxillary excess have a 2-3 stage, like mild, moderate, and severe. Mild to moderate type of cases can be treated by this lip repositioning or combination therapy. But in severe type of cases, you have to go for the orthognathic surgery and orthodontic intrusion, because it's a major surgery. Most of the time, patients don't want to go under this type of surgery. But this is the one option in severe type of vertical maxillary excess. So this is the Leafort 1 osteotomy and superior impaction, where osteotomy is done in this infranasal area. Some part of bone from maxilla is removed, and this portion is superiorly impacted, so reduces the gummy smile. Aesthetic crown lengthening or soft tissue crown lengthening, where this is only soft tissue problem, where gingiva is overgrown at the cervical margin. In these type of cases, you have to just remove the some 1 to 2 millimeter strip of gingiva as per according to measurement and marking. So this is the very simple and very commonly employed procedure for correcting the gummy smile, especially in those cases where length of clinical crown is shorter than the anatomical crown. Clinical crown is that part of the crown which is visible in the clinic or oral cavity, and anatomical crown is that part of crown which is covered by the enamel. So sometimes clinical crown is shorter than the anatomical crown. In those cases, if only soft tissue problem is there, then you can go for the soft tissue crown lengthening or aesthetic crown lengthening. But sometimes here, due to not only soft tissue problem, some bone is also covered in those areas. You have to reflect the flap, remove some bone from 1 to 2 millimeter bone and expose the cervical line. And after that, so that is sometimes only soft tissue problem, sometimes soft tissue and hard tissue problem. So you have to treat accordingly what kind of problem is there. Orthodontic intrusion, as I discussed, orthodontic intrusion is also a process of there, like 1 to 2 millimeter or 2 to 4 millimeter can be achieved with the help of orthodontist. But again, it's a time taking and long procedure. Botox is a very common, and it's again lots of popularity in last 1 or 2 decades. Botox is very popular. Botox is a kind of neurotoxin which is given to the involved muscles, so that muscles become less active or hypoactive, and their result is less exposure of gingiva. So Botox is very common, but only problem with the Botox, because its shelf life is short, and you have to prepare immediately and give, and result will come within 7 to 15 days and last up to 3 to 4 months. So in case of Botox, it's a good thing and non-surgical approach, but patient need to repeated injection at every 3 to 4 months or 4 to 6 months, depending upon their problem and their built up their musculature. So it's a very popular. These are some common point of Botox. Although these points are not fixed, you have to identify which muscles is more active. So according to that, you can give. But in most of the cases, mild to moderate type of gummy smile can be corrected with the 20 unit of Botox, and result comes within 5 to 15 days and last up to 3 to 4 months, depending upon the person to person. So, but this is the very common and non-surgical approach to correct the gummy smile. Now come to the lip repositioning post surgery. So I will discuss about a little bit lip repositioning post surgery along with some other cases which I have combined. It is the surgical lip repositioning procedure was first described by some plastic surgeons like Rubinstein and Kostionowski in 1973. Since then, many modifications have been done, but the basic technique remains the same. And the goal of the surgery to limit the movement of the lip elevator muscles, which are responsible for lifting the lip in superior direction to reduce the gummy smile during the exposure. How to assess the treatment, how to go for the, you have to assess 2 things: amount of alveolar mucosa, how much alveolar mucosa is available. It is very important. In normal or most of the cases are in cases of normal lip line, 10 to 12 millimeter of mucosa is there. Mucosa is that portion of soft tissue which is coronal to the apical to the mucogingival junction and between the vestibule. So this is the loose areolar tissue that is called alveolar mucosa. And in cases of extreme lip line, especially area of lateral incisor, sometimes it is up to 20 to 30 millimeter there, because cervical incisor length of lateral incisor is less. So its availability of alveolar mucosa is more in those areas. Now come to the depth of the vestibule. How to assess the depth of the vestibule? Because depth of the vestibule is not a fixed position. It is a dynamic tissue. It is movable tissue. So sometimes it's become very difficult to assess the depth of the vestibule because of the mobile nature of the soft mucosa. It is difficult and somewhat arbitrary to assess the vestibular depth. But by holding the lip and asking the patient to smile, the experienced surgeon can visualize the outcome to decide how much mucosa to remove. Usually a mucosal strip of 10 to 12 millimeter of thickness is removed apically from mucogingival junction to serve the purpose. When we, in my experience, what I have found, when we are removing 10 to 12 millimeter of mucosa, we can get 4 to 5 millimeter of down of lip in coronal direction. So by removing 10 to 12 millimeter thickness of alveolar strip, we can get correction of 4 to 5 millimeter of gingival display. This is the picture where I have made to just show what kind of, this is the lip. These are the external portion of the lip, and this is the internal hair. Tooth is placed. This is the free gingival margin somewhere here, and this is the mucogingival junction. So this is a mucogingival junction, and this is the vestibular fornix or height of the vestibule. We have to give two incision, one at this vestibule line and another at the mucogingival junction. And now extending these both the incision on distal direction and connect in a rounded manner. And again, and after that, you have to remove the mucosa. And after removing the mucosa, this vestibule is shifted here. When we are shifting this vestibule in downward or coronal direction, this whole lip moves downward. When this loop downward, it's just like when putting down a curtain. So when lip come down, then it reduces the display of the gingiva and correcting the gingival display. So this is the whole concept of lip repositioning. Lip repositioning means position of lip is reposition, means from here it is shifted here. Vestibule is, we are reducing the vestibular depth, or you can call reverse vestibuloplasty. Sometimes as a periodontist, we most of the time do vestibuloplasty to increase that gingiva, other thing. But in these cases, we have to reduce the vestibular depth. So this is also called as reverse vestibuloplasty or lip lengthening or lip repositioning. So this is the basic concept. Before giving the surgery, you have to measure the space from base of the nose to the lower lip. These are the muscles which are responsible for different type of action. Before giving the local anesthesia, or before going to the for surgical procedure, or before giving Botox, you have to assess which muscles is more active. Like these are the muscles which are responsible for different type of action, like levator anguli oris, it lifted the angle of the mouth. Levator labii superioris, it elevate upper lip. Like if this is more active, levator anguli oris, then angle portion of mouth is more lifting is so. If whole lip is lifting, then levator labii superioris alachnizai. And another muscle, levator labii superioris alachnizai, it elevate the upper lip and dilate the nostril. So it's a very specific type of muscle. Its name is very long, levator labii superioris alachnizai, and it is a very shortest muscle, one of the shortest muscles of the body. It is also called as Elvis muscles because Esther star like this Elvis Presley action was very famous for this using this muscle, and zygomaticus major and minor are responsible for the elevation of the corner of mouth. This is this type of action, like where some corner of the mouth is elevated and nostril is dilated. So this is also named Elvis muscle after this superstar, Hollywood superstar. Now these are the different type of muscle, like levator anguli oris, which lifted the angle of the mouth. This is the levator superioris group, which elevate whole upper lip. This is the zygomaticus major and minor, which elevate the corner of the mouth. So when we are going to for giving Botox injection, then you have to identify and give accordingly on those points. And during surgery, you have to also keep in the mind which portion is more visible, or which is which area you require to remove more or less mucosa. Aim of the technique, like surgically correct gummy smile while limiting the retraction of the elevator muscles. These are the zygomaticus major, minor, levator anguli or obliquoris oris, and levator labii superioris and alachnizai. So you have to identify the muscle and limit their action. Procedure like any other procedure, first you have to go the pre-surgical wash with the 2% betadine and anesthetize with the lignocaine hydrochloride 1:80%. And the surgical area to be operated was demarcated with the help of dermy marker, because where you are going to give the incision, first you have to mark with the indelible pencil or derma marker. Derma marker is especially a marker pen with which you can mark the intraoral tissue. So this is the diagrammatic presentation, like this is the teeth, this is the free part of the gingiva, free gingiva, this is the attached gingiva, this is this dotted line is the mucogingival junction, and this is the vestibular height, vestibular fornix. Dotted line is this is the for giving idea where you are giving incision. You have to give incision on this dotted line from here to here. Suppose your smile line is covering up to canine, then you have to give this incision canine. Sometimes it is go up to the premolar, first premolar, second premolar. So according to that, you have to extend and connect. So after connecting these strip, you have to remove these strip like incision. You have to give one incision at mucogingival junction, one at the in vestibular fornix at distance between around 10 to 12 millimeter, but that is not fixed, but most of the time 10 to 12 millimeter. And after connecting both incision and distal side, you have to remove this strip by partial thickness flap, raising the partial thickness flap. So here I'm going to discuss a case. 24-year female was there. Chief complaint was gummy smile. Medical history was non-contributory. Although it was a case of orthognathic surgery, but patient was not ready for that, and we have explained everything that you will get some result, not 100%, but you will get some result. And patient was also in hurry. So after explaining everything, we performed the surgery in this case. On clinical examination, bilateral symmetrical face was there, lips were incompetent, a moderate display was there from molar to molar area. Since crown length was appropriate or optimal, so there was no scope of crown lengthening. Attached gingiva was also normal, and around 15 millimeter alveolar mucosa was there. So you can see we have given two incision, one at the mucogingival junction, another at the vestibule. After giving both the incision, this portion of the alveolar mucosa is removed with the help of by raising partial thickness flap. So this is the removing of the mucosa. Again, this is the after removal of the alveolar mucosa. These are the exposed connective tissue, and this is the flap approximated with the continuous locking suture. So in this case, we have shifted vestibule in coronal direction and limiting the gingival display. So this is the result pre-operative and post-operative. You can see although it is not 100% cured, but almost 70-80% problem was addressed, and this was the pre-operative and post-operative. Although patient was very happy at this stage, but we have advised two more procedure for the patient. One is gingioplasty, because margin of the gingiva was rolled out. It was not knife edge, and some you can see some spot was there. Like, so we also plan for bleaching. So we do two more procedures, gingioplasty and bleaching, both with the help of laser. So this is the post-laser gingioplasty, and this is the post-bleaching. So we applied three procedures in this case, like gingioplasty, lip repositioning, and bleaching. So with the help of three procedures and multidisciplinary approach, this type of result we achieved, like pre-operative, and this is the post-operative. You can see amount of gingival exposure is reduced. This rolled out or gingiva is become thin edge gingiva, and these yellow dirty spots were already resolved with the help of bleaching. So this is the case where we get. This is another case, female of 21 years of age. Chief complaint was again gummy smile. Medical history was non-relevant. On examination, bilateral symmetrical face was there. Lip incompetent. Maxillary molar to molar display was there. And in this case, crown length was short, so there was scope of crown lengthening. Hyperpigmented gingiva was there. Patient was also concerned, so there was scope of gingival pigmentation was there. Depigmentation was also there, and attached gingiva was normal. So in this case, we have you can see all the gingival margin at one plane, like central incisor, lateral incisor, canine, all are looking up the same height. But first of all, we have marked this area, like this is the mucogingival junction, and again mark in the vestibular fornix. After giving incision and connecting at the distal side, remove the alveolar mucosa, and this is the connective tissue exposed. You can see. And after that, giving the continuous interlocking suture and shifting the vestibule in coronal direction. This is the healed area after 4 weeks of surgery. You can see nice healed new vestibule is developed here. Next step for completion was the aesthetic rehabilitation, like crown lengthening and gingival depigmentation. So we performed procedure like crown lengthening. Again, I like to mention here, we have to keep mind in this rule, like cervical margin of central incisor and canine at one level, and gingival margin of lateral incisor is a little bit 1 to 1.5 millimeter, 2 millimeter, coronal to in those like central and lateral. So this is the aesthetic appearance before crown lengthening, and this is the after crown lengthening. You can see here all the gingival margin is at one plane, like central, lateral, and canine all are looking up same height. But this is not required because central and canine are bigger, lateral are gives some delicate look. So after that, we have given individualized correction of these two, like central is longer, canine is longer, and this lateral is shorter. And if you draw a line from central to canine, it is one plane, and this lateral incisor is different plane, somehow 1 to 2 millimeter coronal to these two lines. Like you can see the difference, spot the difference, half side is corrected and half side is not corrected just after the crown lengthening. And if you draw the line to central the canine, it is at same plane, and lateral level of lateral gingival margin is at different plane. So this is required, and this is the after complete both sides post crown lengthening by external bevel incision. And after that, we have gone for gingival depigmentation by diode laser. So this is again the procedure. This is the post gingival depigmentation immediately post after diode laser. So this is the beauty of laser. There is no bleeding and no pain to the patients. So this is the complete case. You can see this is the pre-operative and this is the post-operative. You can appreciate 3-4 major changes, like display of gingiva is reduced here. Color of gingiva is changed from black to pink, and the shape of tooth is changed. Like central is look like the central, canine is bigger, and lateral is delicate. But in this case, all are of the same line. So we have implanted different procedure like crown lengthening, depigmentation, lip repositioning, and this is the again multidisciplinary approach to correct the overall smile of the patient. Again, a case report. This was again 23-year-old female was there. Medical history were non-contributory, and chief complaint dirty teeth and gummy smile. So patient was more concerned about these spots. So with we explained her, because you have a gummy smile also. She was ready, but she wanted to correct these spot first. So it was protruded maxillary central and lateral with deep bite was also there. Was scope orthodontic treatment, but patient was not ready for those things. Some fluorosis stain was there. So and gingival hyperpigmentation was also there. So we have done like this is the bleaching pre-treatment photograph, and this is the result after two visit of vital bleaching. So you can see these spots are resolved or removed with the help of laser bleaching. Again, this is the pre-surgical photograph. Surgical area marked with the dermy marker, like incisions for giving incision. These areas are marked. Incision given and epithelium is removed. You can see this is the excised epithelium. This is the connective tissue exposed area after removal of the epithelium. You can see some fiber are there. You can see at this level, if you find some muscle fiber are hyperactive, then you can snip out or cut out those muscle fiber also. Or many people, some modifications are there. Some people are placing some separator also in these areas so that prevent the attachment of muscles. So this is the suture place, and this is healing after 1 month. So you can see the new vestibule is developed here. And after that, gingival depigmentation by using diode laser. And this is the final result. You can see again 3-4 changes, like this is the spots fluorosis stain were resolved with the help of bleaching, and gummy smile is reduced with the help of lip repositioning, and gingiva, this black hyperpigmented area of melanin pigmentation was removed with the help of depigmentation. This is the again case of 34-year-old female. You can see very high smile line, lot of gingiva is exposed, and this hyperpigmented area. So she was concerned of all those things. On examination, there was attached gingiva normal, hyperpigmented gingiva was there, short clinical crown was there, incompetent lip was there. So we decided 2-3 procedure in this case also. This case is also published in Journal of Periodontology and Implantology, Implant Dentistry. Dr. Chetan was my co-surgeon in this case. I hope, Chetan, you remember this case. This is
Yes,
the
sir.
published case. You can see in this case, we have given incision. After giving incision, remove the alveolar mucosa, and after the suture are placed in this case. And before this procedure, we have also measured the crown length. So how much crown lengthening was possible. So we did all these three procedures in the same case at the same time. So this was its own kind of case where three procedures are employed at the same time, like crown lengthening, gingival depigmentation, and lip repositioning. All the three procedures were employed at the same time, and it was lip repositioning, crown lengthening, and gingival depigmentation. So at that time, our department was not equipped with laser. So after lip repositioning surgery, we performed this gingival depigmentation with the help of scalpel. This was beautifully done by Dr. Chetan, like crown lengthening and this depigmentation or removing of this partial thickness flap. And because it's always done by the surgically, so Copac was applied in this case. And you can see the different type of result. But this is the result. Like again, 3-4 changes are there. Black pigmented gingiva is changing to pink gingiva, and almost 60% of gingival exposure is reduced, and length of crown is increased. So these are the cases. And again, one case is there. This is you can see the severe type of gingival display was there. This was again done in our department when I was working with the Sardar Patel Dental College. This is again published case in the World Journal of Pharmaceutical Research. So you can see in this case, this is the pre-operative case. This is the marked by derma marker. Incision was given. This is the excised tissue, and this is after connective tissue exposure. And after that, we remove some tissue tag and some muscle fiber in this case because it's a very severe type of display was there. And this is after suturing half side. This is complete suture. And this is after suturing. We did assisted laser assisted crown lengthening and depigmentation was also performed. And again, this case was 3 procedures performed. But in this case, we have performed crown lengthening and depigmentation with the help of diode laser. And this is the final result. So these type of cases where you can employ different type of technique, and some modifications are there because some people, if they are afraid of blood or bleeding or scalpel, then some modification are there. You can remove this tissue with the help of laser marking. First, you have to do the laser marking and connect this marking with the help of laser and remove the tissue. So you can see in these cases, some bleeding less or almost no bleeding is there, and some discomfort is also reduced. So this is another modification of lip repositioning with the help of laser assisted incision. And again, this is the case of depigmentation with the help of laser. You can see this is the pre and this is the immediately after the surgery, and this is after 3 weeks. So beautiful gingival color is achieved. Now come to the what are the different type of combination therapy now, because nowadays these are the surgical therapy, but some latest trend of combination therapy is arrived where we correcting this problem with the help of Botox and filler and sometimes lip repositioning. So surgical, non-surgical, all type of procedures is employed with the help of on the basis of the diagnostics. So what is the how to treat the gummy smile? Because you have to identify the etiology. If inadequate tooth exposure, then you have to go for the aesthetic crown lengthening. This is the simple. If adequate tooth exposure is there, but still gummy smile there, because in these cases, because the sub part of tooth is covered with the soft tissue, so you can go for the crown lengthening. But here, tooth exposure is already optimum, so there is no scope of crown lengthening, but still gummy smile is there. In those cases, and the major surgical treatment, orthodontic surgery will lip repositioning, Botox therapy, and filler in lip and nasolabial fold to reduce the gummy smile is also there. Like the combo treatment, you can go for the aesthetic crown lengthening, lip filler, and Botox. Like suppose these are the area where gingival display is 6 mm crown length and with is 8.5 mm. So you can improve with the aesthetic crown lengthening, like you can reduce the gingival display 2 to 2.5 mm with the help of aesthetic crown lengthening. And if you give the lip filler, lip will also become bulky and come down to 1 to 1.5 millimeter. So if this is 6 mm, and you can achieve 4 mm of result with the help of aesthetic crown lengthening and with the help of lip filler. But again, if you want to more result, then in those cases you can again add Botox. If you place the Botox along with the filler, you will get again 2 to 2.5 millimeter of shifting of lip in coronal direction. So you can get 2.5 millimeter with the help of aesthetic crown lengthening, 1 to 1.5 millimeter with the help of filler, and with the help of Botox 2 to 2.5 millimeter. So we can get reduce 6 mm of gummy smile with all these three, like aesthetic crown lengthening, lip filler, and Botox. So this is the combination therapy, called as combination therapy, with the help of surgical as well as non-surgical technique. This is not my case. This is the case taken from some other my friend periodontist. This is the some type of sometimes cases are not symmetrical. That's like this is the non-symmetrical case. One side gingival display is there and the smile is canted. So in these type of cases, you can give one side filler and one side Botox. So you can correct these type of smile with the help of filler and Botox on unilateral. So the important thing in these type of cases, you have to identify the problem, content of the problem, extent of the problem. Then, and according to that, you have to treat. Like in this case, if problem was unilateral, then you have to treat unilaterally. In this case, one-sided given Botox and one-sided given filler, and you can see that this is the balanced smile with the help of Botox and filler. But only problem with these type of things, then you have to go for repeat procedure of every 4 to 6 months. Like for Botox, I mean 4 to 5 months, 6 months, and for filler, depending upon the filler, some filler may last up to 1 year, some filler may last up to 1 to 3 years. So according to you have to go per refill all these things. Again, this is the case of gummy smile, which is corrected non-surgically with the help of Botox and filler. Botox have placed down the lips, and filler have given volume to the lips. So this type of you can see the gummy smile is corrected with the help of Botox and filler. So this is the non-correction, again non-surgical correction of gummy smile with the help of Botox and filler. These are the combination therapy where you can see this is the broken tooth and severe gingival display was there. In these cases, like aesthetic crown lengthening was done, lip repositioning was done, Botox was given, and even after that there was some gummy smile. So some fillers were placed, and after that you can see this is the, you can see the result from here to here. So a lot of improvement is there. And after that, some veneer were also placed for discolored teeth. So multiple approaches are there for, as per the problem of the patient. In those cases, you have to identify the different problem and treat them differently. So this, you can see this is the before and after result with the help of aesthetic crown lengthening, lip repositioning, Botox, filler, and veneers. So this is the result of 5 procedures. You can see. Now, what's new is going in the treating the gummy smile around the world, around the globe. So new thing is there, it's I will not call new thing. Some spacer are applied because in some cases there is a notch in the maxilla. In the superior to this area, there is a notch which restrict the lip to come in coronal direction. So in these cases, you can raise the full thickness flap, and after raising the full thickness flap, you can mold a spacer, or you have to give a bio volume with the help of bone cement. For that, you have to go for a 3D printed model. If you want to reduce your surgical time, go for the 3D printed model and prefabricate this bio volume on 3D printed model. And after raising the flap, you can place this spacer or bio volume here and fix with the help of 2 screw. And after that, you can suture. So it will give you a volume and train the muscles to shift in the or hold the lip more in the coronal direction. So this is again procedure to reduce the gummy smile. This is called the bio volume, and this bio volume earlier cases I saw you have achieved with the bone cement. You can also achieve with the help of a sticky bone, like after raising the flap, make a strip of sticky bone and place this sticky bone and suture it. So this is again going to increase the bio volume. So this is the another method to reduce the gummy smile. Again, nowadays gingival smile treatment associating two surgical. One is aesthetic crown lengthening to increase the short appearing teeth, and again lip repositioning associated with the PMMA, polymethyl methacrylate based bio volume to solve muscle hyperactivity and jawbone depression. So if jawbone depression is there, then you have to make a PMMA strip outside the mouth with the help of a 3D printed model. And after surgical exposure or during gummy smile correction, you can place this. So it will give a bio volume and solve the muscle hyperactivity and also reduce the jawbone depression, because PMMA is a bio-friendly material, biocompatible. So you can place inside. Like this is the 3D printed model. On the 3D printed model, you can construct this PMMA strip, and there you can see 2 points are there for fixing with the screw. So you can fix this bio volume with the screw, and you can reduce this notch. When you reduce this notch, this muscle will train to lip will hold more in coronal direction. So these are the anatomical correction. This is the PMMA strip. You can place with the surgical, like if you give a one incision here, you can place one this side, and place with the help of screw. So this is, you can see the pre and post result. Again, this is the case of this is strip, and this is the crown lengthening was there. So this is the prefabricated stent for giving incision. This is those who are not very good at the surgical hand, they can get this prefabricated stent or customized stent for giving incision. But as a periodontist, I don't think for periodontal people this is a requirement of this type of stent or any type of, because you can do freehand. So this is the pre and post result, you can see. Again, this is the case of bio volume, increasing the bio volume with the help of PMMA material. You can see the pre and post result. So after this conclusion is this, like crafting an ideal smile require analysis and evaluation of face, lip, gingival tissue, teeth, and appreciation of how much they appear collectively, because you have to identify the problem very carefully, because if you are missing at this space, like identifying the problem, then you will end up with some other type of problem. And you have to very good idea like how all will look collectively, like correction of lip with the help of either Botox or lip repositioning, gingival display reducing by crown lengthening, or with the help of veneer and some, because when we are employing multiple procedure, then you have to very clear cut idea how it will look collectively after employing all these procedure. Such an ideal smile depend on symmetry and balance. Symmetry is also required, because sometimes it is required on both sides, sometimes one side more, one side less. So you have to keep a balance on this type. So dental features, the color, shape, and position of teeth all are part of the equation. Recognizing that allow function and that the anterior teeth serve a vital role in the overall health and well-being of patients is of paramount. A comprehensive approach to diagnosing and treatment planning of aesthetic can help achieve that smile that best enhances the overall facial appearance of a patient and provide additional benefit to enhance oral health. So excessive gingival display is associated with a different etiology, which must be identified before the treatment. I stress here, you must identify the etiology of the gingival display, then go for the treatment. Lip repositioning is an innovative and effective way to improve the gummy smile of the patient, although it has a limited indication. But in some type of cases, it is very effective, like where crown length is already normal, but still gingival display is there. Then for general practitioner and people don't think what to do, because most common employed procedure to correct gummy smile is the aesthetic crown lengthening. But when length of crown is already optimal, in those cases, the lip repositioning is very effective. This technique is easy less time consuming and cost effective technique to provide a satisfactory result for the patients. With these things, I would like to finish, but before that, this is my YouTube channel. It is on YouTube already, where is a video on lip repositioning, where the cases of 5 cases are there already. More than 60,000, now 62,000 views are there around the globe. So for those students or general practitioners, those who want to correct the gummy smile or learn about there, they can visit this site, like and subscribe and download the video. And some other important video for students are there, like laser assisted some procedure, lip repositioning, mucosal and maxillary central incisor, immediate implant, and sinus lift, direct sinus lift, lip repositioning. So these cases are there. If anybody wants, they can visit at this site. And with this all, I would like thanks to all of you for your patience hearing. If you have any question, you can ask me, and I am available on this platform, so you can go also there. So I would like to stop sharing here. Dr. Chetan.
So thank you so much, sir. After hearing a lecture, now I think it has been clear to all the audience that surgical smile designing requires a holistic approach and a multidisciplinary approach. So having a holistic approach will actually lead you to the right way to justify smile designing. I'm really thankful to sir. Why? Because sir has always been a person who always took challenging cases. And I'm proud to say that I have been an integral part of his surgical team. And the trust and the faith he's shown on me has been, it's a blessing in disguise, sir. Regarding the questions, we have a question that what are the complications of lip repositioning surgery?
Usually, if you do go properly, there is no complication. But like any surgical procedure, it has its own merit and demerit. Like sometimes some minor salivary gland or some minor sebaceous gland are injured, and their opening is you can do constricted. So sometimes some mucosals appears after the surgery, but this is a very rare reported case. And like any other surgical procedure, like post-operative pain, swelling, and some other disc complication sometimes may happen. But if you employ the procedure properly and use anti-inflammatory properly, I don't find any major complication after the lip repositioning surgery. Some little bit, swelling, edema there, like, so that is the common part of any surgical procedure. When going to perform any surgical procedure, then you have to ready for these all things. But so I don't find any major.
Right, sir. So like we do Botox and fillers for these procedures. So do you think there is some limitation for these in regard to the systemic health? Though we know that it is time, it might return to the original after some time. So any systemic issues, do you think that should we go ahead or should we not use them? What is your take on this?
No, Chetan, you can see there is nothing 100% for everything. You know, everything has their limitations, some indication and contraindication. So Botox has some contraindication, like if some person is having some neurological problem, then you don't need to give. But as a surgeon, I love to do the surgery. I love to play with the scalpel. I love to do with the surgical procedure. But sometimes, you know, patients are very hesitant. They are not ready for the surgery. They don't want to go to a scalpel. They want to immediate results. So in those cases, we can go for this Botox and filler. And sometimes even in some severe cases where after lip repositioning, after crown lengthening, everything, but there is something missing, like lip are thin and something 1 or 2 millimeter, you can play with the help of filler also. But only disadvantage of these things, because it's more or less costly. As a surgeon, I find it costly, because what I can achieve with the help of 2 rupees of BP blade or scalpel, for that you have to buy my 20,000 rupees of Botox and 20,000 for filler. So again, it is going to cost the patient pocket more. But even after that, sometimes patients are ready to pay that because he doesn't want to undergo the knife.
Thank you, sir.
In those cases, it is good to use Botox and filler. And nowadays it is gaining popularity. A lot of people are doing, even I do in lot of, like in some you can black hole disease or some minor gingival papilla is not there. You know, as a periodontist, creating a last papilla is a very difficult procedure. And even if you get the result, how far it will be maintained for how much time, even I don't know. Even patient don't want to go for surgery for a 2 millimeter of black hole disease. So in those cases, put a few drop of filler and you get result in 2 or 3 days. So that is sometimes it's a very useful.
Yes, sir. True, sir. Dentistry is a multidisciplinary approach, and every dentist should have a holistic approach to achieve the best. So nice, sir. Wonderful
Sure.
lecture, sir. Sir, over.
Thank you,
I would
Chetan.
request Dr. Ben, sir, to please take over the proceedings, sir. Dr. Ben, Head of Department, Saraswati Dental College, Perio Department. Yes.
Thank you, Dr. Chetan, and thank you, Dr. K.K. Gupta, for wonderful lecture, for such a elaborative. You have elaborately explained the procedure, and I guess our postgraduate student must have learned this technique from you, and further you have shared your YouTube videos of these procedures. So that will be helpful to us, helpful to everyone. And many faculty members also joined this. I'm thankful to all the faculty members who have joined, all the postgraduate students who have joined this lecture series. And thank you very much, Dr. I'm just on behalf of Saraswati Dental College and Department of Odontology, I'm sharing a certificate of appreciation with you, sir. We will send this certificate to you by email. And thank you very much once again, sir. Thank you.
Thank you, Dr. Bench, Professor and Head Department of Periodontology, Saraswati Dental College. Dr. Chetan, Professor of Saraswati Dental College, and all the listeners who have they spared their time to listen me carefully. And thank you very much for giving me an opportunity to share my experience with budding periodontist and general practitioners and all those who are present during today's presentation. Thank you so much
Thank
for
you.
a beautiful certificate.
Thank you.